question 3, so what are the actions? Well, in terms of investigations, so that's the first one, investigations, then we look at the interactions, and then we look at how we get that information to everybody. Investigations and interventions is the first I. So we just wondered what her glucose control is like, was she, running really low or really high, at times when she's most irritable. We could request these things, right? If they haven't been done, is to do the DOS. One of the things that's very important about the DOS is that it is time limited, because sometimes people think this is an endless exercise. And when you look at that, that looks like a very daunting task. And if people are new to it, you need to sell them on the fact, we'll do this for 3 days, we'll do this for 5 days, and then we'll talk about what we see. Because the way to engage people, of course, and that's why P.I.E.C.E.S is all about conversations, when you have conversations, the next time it happens, one of the care staff will say, maybe we should do a DOS. So we've looked at the CMAI, we could do a no pain scale, and we could certainly make sure that her MMSE is stable and it hasn't changed, and look at that. So in terms of P, review the goals of care. She likes to eat treats. How much are we going to really kind of get in the way of her doing things that she actually gets pleasure from? Minimizing the number of drugs that we can, because she hates taking medication. So that means every time that the nurses have to interact with her, it's often around medication. She hates it, so therefore there's going to be an unhappy interaction. So can we look at how we can minimize passes or minimize the number of medications? Look at maybe a trial of regular analgesia for a period of time, not endlessly, but maybe look at a 2-week trial of some regular acetaminophen and see whether pain is really kind of an issue that she's not able to engage with. And is there some kind of new illness, looking at her in some detail. The I would be, we know that one of the things that, so it's the 7 A's plus an E, that's really what we should have said, but we know she has executive difficulty, and we know that we need to build, so we really need to look at whether that has changed. Is it worse? What's happening with her intellectual function? We said we didn't really know if she had anosognosia. We need to go back and have that conversation with her. We need to see what her receptive abilities are at this point, because they could be changing. And that you can do in a conversation. It's not like you have to go in with some fancy tool. You have a conversation and just keep these things in mind. And then once we know, building that reactivity and her executive dysfunction into a behavioral care plan. The E, we want to review SIGI CAPS, so sleep, interest, guilt, energy, concentration, appetite, psychomotor agitation or retardation, and suicidal ideation, to see whether depression could possibly be an issue. And we don't really have much, there wasn't much mention about past history of depression. So again, we have to do a little bit of digging. So this is all in the intervention investigation piece. And then C, make sure that her current abilities are reflected in the care plan. So that means actually really having a look to make sure that what we say we should be doing is what she actually needs. And then E, the environment, and then providing some post-trauma support to her daughter. Because the thing is, as I was getting ahead of myself and saying, her daughter still can be a resource. Her daughter might need some support to get there, or maybe she can't. But we don't really know that. And so we really need to engage with her daughter and see what it is she's needing in order to support her mom. Maybe we could really look at how much is she being engaged in meaningful activities. So if she's not going to get dressed in the morning, doesn't mean you can't do her nails. So we're going to try and find ways to connect with her that actually support developing a relationship and support the things that maybe are getting in the way of her getting things that she actually wants. So start with something she will agree to, and then hopefully gradually get her dressed, etc. So manicures, fashion, the gardening piece is really key. Does she have funds for a regular companion to take her outside? So in terms of the interactions, we want to engage her in the care as much as possible because she's such an independent individual, right? So we want to make sure that she feels like she's in charge and we're supporting her rather than we're telling her what to do. The trial of a pocket talker. Fascinating how many people will not wear a hearing aid, but they will wear one of those pocket talkers. Does everybody know what a pocket talker is? Oh man, they are your best friend when you're working with somebody who's hard of hearing who won't wear a hearing aid. They're a little pair of earphones and a little speaking box with a microphone on it. And because it's simply an amplification system, people often, they will hear very well with it, and it's not putting something directly into their ear, it's just sitting over top. stop. So they're often very willing to wear this, and it changes your whole conversation. So she may not wear a hearing aid, but she might put on a pocket talker. And once you can have those wonderful conversations with her about what's meaningful, it could also start to transform things. So making sure you approach on the side of her best hearing. Approach on the diagonal. So as you saw, don't come in from the side. Come in where she can see you. She's a woman who also really needs control. So no, don't come up from behind and tap her on the shoulder. Come around so she sees you and so she can engage with you. Use the stop and go technique. This is, oh man, this is like such common sense. It's amazing when one has to actually teach it. But what happens is in caring for Ellen is people want to get in and get out as quickly as possible, right? So when Ellen starts to get fussy, you just add another person on, and then you keep kind of, so you can get the thing done as quickly as possible. Instead, what we try very much with gentle persuasive approach is saying, as soon as I see Ellen, I really get to know when Ellen is starting to show she's getting irritated, and I stop, right? I stop, and I just check in with Ellen, and I check in with myself, because I can guarantee you when Ellen's energy starts to rise, my anxiety is going to start to rise too. And we sort of say, can I re-engage, or maybe I should just go and do something else and come back? But people are so desperate to get their work done that they will just often push through, not recognizing that not only is it dangerous for them, not only is it not good for Ellen, but it's even worse for the next crew who has to come on and provide care for Ellen, because she gets more and more conditioned earlier on in the interactions to become fearful. So it's a very important technique, and it's very simple. Stop and go. Incorporate her pride and her parents. Do the minimum of the care in the evenings, because the evenings are harder for her, so make sure you do the most of your care in the morning, and schedule regular times for meaningful activities, like making sure she actually does get out and enjoys some time outside.
Now that information needs to get translated some way to a care plan. So that's what is meant by individualized or person-centered plan of care. So you've got to take all that information and you've got to put it someplace so that it can now be communicated to the next person coming on shift and the care aides. And so you have a copy of behavioral care plan for Ellen. It's also a behavioral support plan in your handouts. I'm just going to read a little bit of it, just so you get a sense of the person-centered approach. So the focus: I am quick-tempered. I don't like it when you try to help me get dressed or washed, when you tell me no, when you don't meet my requests, or it's too noisy. I will swear, mock, and belittle you, raise my fist, hit, or pinch you. So if I was coming on to give care, I call this like starting the care choreography, actually. And I read that, so already I'm kind of getting a sense of what I might face. The goal, though, is to reduce that. And here's how we do it. And this is the non-pharmacological stuff, the eco-psychosocial. This is how you put it all together. I like to sleep in. I am one person caring. Always approach me from the left side. Use the pocket talker to introduce yourself. Be respectful. Simple, short sentences. Don't ask me a lot of questions. I prefer familiar caregivers. If I have a new care aide, reassure me. And here's a bit of text that you can use. Conversation, scripted conversation. In quotes, good morning, Ellen. Tony is off today. He's the favorite. But he left me a list of all the things you like. I feel more comfortable with staff who are confident. I always have a cup of tea, Earl Grey, 2 creams, 1 piece of toast with jam, no butter, before I get up. Do not rush me. Ask me, are you ready for your spa treatment? As opposed to, let's get into the bathroom and get changed now. We can do your hair afterwards. Put on your lipstick, real your lipstick. If I start to mock you or become sarcastic, oh, everything is a real jive, use the stop and go approach. Give me a minute and connect with me. Ellen, I'm so sorry I upset you. You have such beautiful clothes. I just wanted to help you get dressed. If I continue to escalate yelling, get out of here. Tell Ellen, I'm sorry I upset you. I will come back in a few minutes. Do not continue. Do not continue, as I will strike out. Okay, so it gives you a little bit of a sense of what a behavioral care plan could look like.